So today's lecture is going to be on glaucoma. Your blueprint, easy, just one disease category. So we'll go over some background, touch on ocular hypertension. We'll go into the different types of glaucoma, starting with our primary open angle, closed angle, and then finishing off with secondary glaucoma. So before we start with glaucoma, let's go over the anatomy of it. So the aqueous humor, that fluid that floats around in the anterior chamber, is produced by the ciliary body. And then it flows over the lens, the front surface of that lens, kind of makes a U-turn around the iris, and then heads towards the trabecular meshwork in the angle. And that acts as our filter system. And then it leaves the angle through the Schlemm's canal. So your normal intraocular pressure, or IOP, is in the range of 10 to 21 millimeters of mercury. In order to establish that healthy balance or that normal range, you want to have a nice flow of production to an equal amount of drainage. So if it gets backed up, then you're going to experience an increase in the IOP. And there is a diurnal variation, so the IOPs tend to be a little bit higher in the morning versus in the afternoon. So here's a schematic drawing of that aqueous flow. So it starts off in the ciliary body, down right in this structure here, right, down in this structure here. It traverses over the anterior part of that lens, makes this U-turn around the iris, and down into the angle. What picture was it in that? Here's another one. All right, so glaucoma. The definition of glaucoma is a group of disease with progressive optic nerve damage and visual field loss. Most cases will have an associated high or elevated intraocular pressure, but just intraocular pressure being high is not enough for the diagnosis of glaucoma. We divide the categories of glaucoma to our open angle versus our closed angle. So with our open angle, you have normal outflow of the aqueous humor. And then with angle closure, there is something that's blocking that outflow of that fluid. So in order to diagnose glaucoma, there's an arsenal of tests that we would do. The first one, which is the easiest one, is the angle assessment. All right, so this is where we are shining a light into the eye, coming off from its side, and we're looking at the illumination over the iris to see if that angle is open. So you'll use a pen light, you're coming at the temporal aspect of that limbus, so not straight ahead, but off to the side. You're going to shine this light, and you're going to see and hope that you're going to have this equal illumination from the temporal to the nasal side of that iris. All right? If there is any shadowing on that nasal aspect, then we would assume that there is something that's blocking that light from illuminating over. So there is a shallower angle or anterior chamber. The more shadowing there is, the more narrow that angle is assumed. So here is that drawing. So the top, that pen light is coming from a temporal aspect, and it's illuminating equally over that iris. And so the iris, the top one, you'll see that it's a uniform color. Right? So the light is coming this direction. It equally illuminates the iris, and you're going to get an even illumination all throughout. Right, so coming in temporally, equal illumination all over the iris. Now, if there is something that is preventing the illumination, so that something is blocking it, you're going to have a shallower chamber. So if you notice, this chamber is going to be a little bit more shallow versus this up here, and you're going to get a shadowing effect onto the nasal aspect of that iris. Right, so this chamber depth more shallow than here. Something is blocking it from illuminating the nasal aspect of that iris. So we also look at that cup to disc ratio. So we're looking into the eyes now at the optic nerve disc where it inserts into the back of the eye. We look at this from a baseline standpoint and then also for progression to see if it deviates from that baseline. The optic disc is where the nerve and the blood vessel leaves the globe as well. And it is our anatomical blind spot. So when we do a visual fields test on a patient, this will be a highlighted black spot on that printout. Your cup to disc ratio is the comparison of the cup, which is the inner right area of that nerve, to the overall disc size. So the smaller that ratio, the less visible that circle on the inside, the center part of that disc is noticeable. And then the larger that number, then we start to worry about glaucoma. So here is how we would look and measure a cup to disc ratio. So the cup is that inner brighter spot of the disc, and this is what you're comparing it to how much of it takes up this outer disc area. So a lot of times when I'm explaining this to my patients, either use a pool noodle or a donut as an analogy. So we're looking at how much of that inner canal, that donut hole, takes up of that actual donut in itself, right? If you have more tissue, it's a healthier nerve. If you have a smaller amount of tissue, or a donut per se, then we start to worry a little bit more. So if you look at the left picture, you'll see that the inner right center of that optic nerve is pretty small. It's almost not noticeable in comparison to that overall disc size. So you're going to have a smaller ratio. So in this case, a 0.1 cup to disc ratio. To the right, you'll see that that center right circle takes up about half of that outer ring, and so we're going to grade that about a 0.5 disc ratio. This, when I see in a patient, I'm not too worried. It looks pretty normal, right, 0.5. But once we get a little bit bigger into the realm of, say, like a 0.8, then we start to worry. 0.9, obviously, it looks a little bit scarier. Some patients are born with just larger optic nerves, larger cup to disc ratio, and that's where you would need additional tests, not just looking at that cup to disc ratio. But there are certain characteristics of a glaucomatous disc, right? And in this case, the 0.8 is showing a little notch. So if you follow the ring of that cup, you would want an even circular pattern, but right in here, it kind of dips in. There's a little notch right here. And this is glaucomatous in nature, right? So you're looking at this inner circle and you want an even circular pattern. But right here, it kind of dips in where there's a little notch. Another example of a large cup to disc ratio. And then you can also have patients who have asymmetrical cup to disc ratio, right? So when you're looking at it, you definitely want to make sure you're paying attention. Not everyone has 0.5 in both eyes. And so you can experience where one eye is significantly bigger than the other, not necessarily glaucomatous. This is where you would still do the additional test to rule out any visual field loss. All right, so that brings us to visual fields test. And so like I mentioned yesterday, it's kind of like the hearing test, but for the eyes. You have the patient sit in, we call it like a bowl, but it's a machine. They rest their chin there. You have a technician that's monitoring and tracking their eye movement. And I always tell my patients that do not stare. When you stare at that center fixation target, everything starts to blend in with one another, and it's really hard to actually see that flickering light. I also tell them that each plot is tested multiple times, because I think a lot of times patients will worry that they blink and they miss it, and then it's going to show some abnormality that's not really there, right? So reassuring them that the test will be performed in the same spot multiple times, so blink if you need to. There's also a pause button if they need to take a break. And so they'll go through this whole test, and then any areas that are missed will be plotted as a black mark onto the printout. The more black, the more worrisome it becomes. And then we also do this test to monitor for progression of the disease. This test is difficult. I mean, every test that we do on our patients, we have done it on ourselves. And this is the one test that I cannot get done both eyes in one sitting. It's exhausting, right? So patients will experience fatigue with this. And when that happens, the results tend to be a little bit inconclusive. So a lot of times you will need to do this test multiple times in order to get a reliable result to make that diagnosis. So here's an example of the printouts that we would see. So in that normal visual field, that left picture, you'll see that black plot that's there, and that is your anatomical field loss or scotoma, and that is where your optic nerve is. The upper right picture is an arcuate defect, so it spans that, it's like an arc pattern across the superior portion, but it can also happen in the inferior portion. And then with advanced glaucoma, you can have total blackness, maybe a little bit of sparing at the beginning, but eventually they can all go away. All right, tonometry, everyone's favorite test when they go in for an eye exam, the air puff test. So you have two different methods. The screening part of it is the air puff, which is the non-contact tonometry. Gives us a quick reading of what that intraocular pressure looks like. But the gold standard is going to be your applinated tonometry, in particular the Goldman applanation tonometry. And this is where we actually put a probe up against the patient's eye, and it makes contact with it, and we get a more accurate reading off of it. This test is done with the patient's cornea anesthetized. It's not very comfortable, and they can feel everything. So this test is done behind the slit lamp, and I think you all will see it when you head on over for the Morgan Lens lab. And so we place the patient behind this machine, and the probe is attached to the slit lamp. So the Goldman is right there, Goldman is right there. The illuminated spot is what comes in contact with the patient's cornea. And what we're looking for is the Myers. So we put an anesthetic with some fluorescein dye and put in a blue filter to highlight that dye. And you'll see these semicircles. And you want the inner corners of that semicircle to touch each other. You push too much, that arc or that Meyer is going to thicken. And if you don't push the machine or the probe in enough, then it's going to be a very thin, so a thin Meyer. And so you want to make sure you have this equal amount. After you do it a couple of times or you've seen it a couple of times, you'll know what thick looks like and what thin looks like. Now, if you push too hard, you can cause some epithelial disruption. I've done this before. My now husband was the poor patient that had to experience this during the second year of optometry school for me. So you do want to be very gentle with this. Artificial tears, a couple of days, everything will heal. But some patients are just a little bit more prone to some epithelial disruption. So before, I think a lot of times when patients think of glaucoma, they think of high pressure, right? But you can have high pressure by itself, and that is what we call ocular hypertension. And so you have a normal looking optic nerve, there is no visual field loss, and that chamber is wide open, but their pressure is above 21 millimeters of mercury. With these patients that have normal findings outside of that high pressure, we would monitor them manually, but there's no treatment that is necessary at that time. This does put them at risk for developing glaucoma in the future, so again, we're still monitoring and looking at their optic nerve and looking for any type of change. So age tends to be a risk factor. Large cup to disc ratio is also one. We'll check their corneal thickness. Sometimes thinner corneas give us a false sense that the pressure is normal when it can actually be a little bit higher. A strong family history, and then those with high nearsightedness. Now, once we start developing changes to our optic nerve, right, and then there's field loss, that's when we start to think about glaucoma. And our first category is your primary open angle glaucoma. This is where there's a loss of retinal nerve fiber layer that causes a reduction in vision. There's a vascular portion and a mechanical portion to it. And unfortunately for us, when we're managing patients with glaucoma, the intraocular pressure is the only thing that we're able to modify. So the pressures tend to be above 28 millimeters of mercury. Right, so normal is 21, so we're above that now. And those that experience high pressures like this are at 15 times more likely to develop any type of field loss. So for POAG, primary open angle glaucoma, the field loss, and that tends to start off with your peripheral vision, is gradual. So they're not going to just wake up one morning and then everything is gone. Right? Rarely are patients experiencing symptoms early on in the disease. And then over time, like I said, the patients will experience severe field loss and it will encroach into their central vision. So the picture down at the bottom kind of gives you a timeline of what a patient would experience with progression of POAG. So normal vision on the left, moving over to complete field loss on the right-hand side. All right, for risk factors. Over the age of 50, African Americans and Hispanics tend to be at a higher risk for developing POAG. Family history, stronger with if your siblings are diagnosed with glaucoma. Diabetes is also related or puts you at a higher risk. So I know we think of high pressure, probably hypertension is also a risk factor for it, but there is no definitive relationship between ocular hypertension and systemic hypertension. All right, so our workup. We're going to measure the intraocular pressure for the patient. You can have normal tension glaucoma where the pressure is normal, but often it is high for these patients, and it's highest in the morning. So when I am doing my intraocular pressure tests on them, I will have them come back throughout the day. I know for our Air Force folks, flyers that are on, that has a waiver for it, part of our workup is to have them come into the clinic 3 times that day, morning, our lunch, and then around right before we close up, just to see if there is any big variations in their intraocular pressure. And it is all done by Goldman, so there is no air cuff test for those folks. They're coming in, they're seeing me, we're anesthetizing the eye, putting that probe against the eye, and measuring it. All right, we're also looking to see how open that chamber is, so just like what we showed a few slides back. And then for those with severe and advanced case of glaucoma or POAG, we're checking if there's an apparent pupillary defect. And your cup to disc ratio, when we're looking into the eye, is about 0.6 or greater. All right, so if you are, as a primary care provider, are suspecting of POAG because you looked into the patient's eye on direct ophthalmoscope, those large cup to disc ratio, you would send them over to us. Right, there's 2 different ways of managing these patients. Typically we do it by drops, and it's either to decrease the production of aqueous humor or it's to increase the outflow of that aqueous humor. So you won't be prescribing this, I will be prescribing this, but when you're doing your intake on your patients and going through their medication, these are the more common drops that we would prescribe or that you would see in the treatment or management of open-angle glaucoma. From my experience, I think the beta blockers and the prostaglandins tend to be more common. Latanoprost, bimatoprost is a big one. I think you'll see bimatoprost, quite a bit because of the fact that a prostaglandin analog, yes, to treat glaucoma, but one of its side effects is darker, fuller lashes. And so a diluted form of it is Latisse. Have you all heard of Latisse? It's this medication that allows lashes to grow a little bit thicker, fuller. I believe a version of it is over the counter as well. All right, so some potential side effects to glaucoma medications. All right, with your beta blockers, you can have decreased cardiac output and bronchoconstriction. Your alpha-2 adrenergitis could cause allergic conjunctivitis or contact dermatitis, and an exacerbation of hypertension with your sympathomimetics, and then some redness in the conjunctiva with your prostaglandin analogs. Now, when meds don't work, then the surgery is the next treatment, and that typically is for patients who have worsening of their glaucoma. You have 3 different types listed there: trabeculoplasty, and that's done with laser, so argon or a selective laser. And then a trabeculectomy, where they are creating a blood or a shunt to help improve the outflow of that aqueous humor. And you can have ablation of the ciliary body, so that reduces the production of aqueous humor. All right. So with POAG, you can have neurofiber layer loss. And so this picture here is showing a little bit of it. It's kind of hard to see, but when you look into the eye, especially for like a young patient, you'll see that there's this sheen over the retina. All right, and when we take a picture of it, it comes off like a lighter color. And so for this picture, if you look at it, but down in this inferior portion, it's a little bit dull in color versus up here. So this down right here, it's a little bit more dull than the rest of the retina up here. And that is typically a sign of some neurofiber layer loss going on. In this picture as well, if you're looking at that optic nerve, what do you notice?
Cup to disc ratio.
Yep. So it's a large cup to disc ratio, right? We're not going to say that that's 0.1. And then down right here, there's that little notch. You guys are ready to diagnose glaucoma?
Got it.
All right, so for that same patient that we just saw, here it's highlighting the neurofiber layer loss. So for that same patient, we can look at that neurofiber layer loss a little bit better with an OCT, so optical coherence tomography. And it'll highlight that area of loss. So that eye was the left eye, so we're going to look at this side right here, and this area right here is showing that neurofiber layer loss. So same thing on this side. This is the left eye that we were looking at with that earlier picture, and then you have your neurofiber layer loss right here. So when we see that, I typically will have my patient come back a different day to do their visual fields test, because like I said, visual fields tests tend to be quite fatiguing for the patient, and we have done a whole lot of stuff leading up to this point. And so I want them well rested and ready to go. And so they'll come back, and areas that have neurofiber layer loss is going to highlight in black. And so this tends to be a mirrored image, and that's why you're going to see, even though you have this neurofiber layer loss, down at the bottom, you'll have a superior, or it's above the horizontal midline loss. So even though it's down right here, you'll have this up here. You can also have disc hemorrhaging going on with POAG or advanced stage stage of POAG. And that's the bright red spots on the disc margin. And then here is a picture of a bleb in the superior aspect of the conjunctiva. And we're seeing this for the first time, and I was just like, I don't know what that is. That looks like a cyst. But then after talking to the patient, realizing that that's just the blood. Right. So another type of glaucoma that's still well within that open angle category is normal tension glaucoma, or also known as low tension glaucoma. And this is where the patient has a normal range IOP, so less than 21 millimeters of mercury. They also have that open angle, but they are still experiencing visual field loss and optic nerve damage. So POAG, open angle glaucoma, you'll have high pressure, you'll have open angle, visual field loss, and optic nerve damage, right? Your normal tension, in its name right there, that the pressure is in the normal range, open angle, but they are experiencing that visual field loss and optic nerve damage. All right, so risk factors, age, females, family history of it, thinner corneas, and maybe obstructive sleep apnea syndrome. All right. So that relation is not fully understood, but it is believed that OSA may induce transient hypoxemia and increase vascular resistance, resulting in damage of the optic nerve, leading to glaucomatous nerve damage. The treatment for normal tensive glaucoma is the same as POAG. A lot of times it's hard to lower their pressure when it's already on the lower end or within that normal range. All right, so we're going to go ahead and jump over to our angle closure now. So there's two mechanisms for angle closure glaucoma. You can have a relative pupillary block. This is where the iris is pushed forward and it closes up that angle. Or you can have a non-pupillary block. And this is where the iris may be pulled or positioned anteriorly, causing that blockage. And it's oftentimes linked with some inflammatory condition. And the aqueous humor gets trapped inside the eye, which drives that intraocular pressure up. So symptoms, patients will experience blurred vision, typically in one eye, and they'll experience halos around light. There's a lot of pain and photophobia associated with this. Patients can sometimes complain about a frontal headache and nausea and vomiting. Things that we would see when we're looking at a patient who has an angle closure attack is that their pupil is a mid-dilated size. There's a shallow anterior chamber. There's redness in the conjunctiva. We have corneal edema, some lid edema, and their pressure jumps up to 60 to 80 millimeters of mercury. If you ever touch an eye, palpate an eye that's going through angle closure, it's rock hard. All right, so risk factors. Females are 3 to 4 times more likely to get it than males. Our older population, so 55 to 70. The non-pupillary block version of it tends to be more common in the younger population. For our race, it's Far Eastern and Indian Asians. Far-sighted eyes tend to be at a higher risk. Family history, stress, so extreme dilation. So when a patient goes into a dark room where the pupils dilate, and then certain medications. All right, so to assess for a narrow angle, and again, this is done behind a slit lamp. What we do is we'll look for the von Herrick measurement, and that's when we do a cross-section of the cornea using the slit lamp light beam. And we're looking at how much of a space there is between the illumination of the cornea and the iris. So looking at the space in between the cornea, which is this white band right here, and then this bright light is the illumination on the iris. So we're looking at the space in between it. And you want that space to be at least half of the width of the cornea. So this white band is going to be your cornea. The bright light right here, this yellow line, is going to be the illumination on the iris. And you're looking at the space in between, and you want at least half of the width of the cornea. And that is an open angle. If it's less than half of it, it's considered a narrow angle. So when you have a patient who has an angle closure attack, the main thing you want to do is to break that attack. So there's a kit with certain medications. Some are an IV, some are topical through an eye drop. I think every optometry clinic should have one, or at least know where is one. Major Heinen and I were talking about it. A lot of times pharmacy will have the angle closure attack kit. So I would, when you get to your MTF, just touch base with the optometry clinic to find out where exactly it is so that you can get that as soon as possible to break that attack. Once the attack is over, all right, then the treatment of choice is a laser iridotomy. Certain medications are still being studied to see if it helps. Shrevpost is a prostaglandin analog, and it takes a little bit of time for the true effects of that medication to kick in. So again, if you're trying to break this attack ASAP, that probably is not the best option. All right, so your LPI, your laser peripheral iridotomy. This is done behind a slit lamp, and basically the ophthalmologist, unless you're in Oklahoma, then an optometrist can do this, that they'll literally burn a hole in the iris to create another option for the aqueous humor to lead and flow for an increase in output through that angle. This is done super quick. It's 5 to 10 minutes. I remember when I was shadowing an ophthalmologist during optometry school, a patient came in with a narrow angle, no angle closure attack, just narrow angle, had some other risk factors that would put them at a higher risk for developing glaucoma. And the ophthalmologist literally just sat there, talked to the patient, discussed it. Next thing you knew, we were doing LPI. This is not a procedure where you need to have them fast or anything like that. It literally is, you put this lens on, laser, literally looked like she was playing a video game. Push the button, heard a pop, and it was done. And the patients are good to go afterwards and back to their normal daily activities. Here's a picture of an angle closure. All right, so that iris is pushed up against the cornea, and this angle is not even visible. All right, so same thing here. This is the iris pushed up, blocking that angle where you can't even see it. All right, and then here's another picture of a patient who has angle closure. So that right eye is the eye that is affected. You have lots of injection going on in that conjunctiva. That cornea is a little bit hazy, so there's a little bit of edema going on there. And then that bottom picture is a picture of an LPI, an iridotomy. So it's this hole that's right here. So it is that hole that is right there. Most of the time when you see patients, I don't think I've seen a patient with an LPI in that location. A lot of times it's tucked up superiorly, so about 10 clock hour to maybe 2. Studies have shown that it allows better opening of that angle when it's done in that superior region, but from a cosmetic standpoint, it's not visible, so people, when they're looking at you, they don't see it. But when you're doing your assessment with the patient, and if you see this like funny looking hole that is on that colored part of the eye, it's probably an LPI. Now, in severe cases, that little hole won't be enough to create an outflow, a channel for outflow, and that's where they will do a peripheral iridectomy, where they are removing a piece of that iris, and that is that triangular shape darkness that's up superiorly. So right there. All right, so we were just talking about acute angle closure. Now it is the chronic version of it. So for history, portions of the anterior chamber angle are closed permanently by peripheral anterior synechiae, so PAS. Synechiae is the sticking of that tissue. Anterior is the iris touching the endothelium of the cornea, right? So I think during your iritis, uveitis lecture, we talked about a posterior synechia, and that's where that iris, the backside of it, is touching the front surface of that lens. Right, so now we're talking about in front of that. So it is the front part of your iris touching the backside of your cornea, the endothelium. Patients will have a history of angle closure attack. And then we talked about some of these conditions yesterday. It's proliferative diabetic retinopathy. Can cause chronic angle closure glaucoma, trauma, uveitis, hypotony, and some sort of injury or trauma to the eye in the form of previous trabecular laser treatment. All right. Usually these patients are asymptomatic. Maybe a little bit of decreased vision and visual field loss, some intermittent eye pain, headaches, and blurred vision. We'll see this on gonioscopy, which is the test that the next slide will show. Broad bands of anterior synechia going on, maybe some elevated pressure. It's usually less than 40. So remember your acute angle, it was like 60 to 80. This one is elevated, but just not as much. And then you're going to see optic nerve damage. All right, so gonio, one of my favorite tests to do on patients. All right, so again, done behind a slit lamp. Right, patient has their head in, there is this lens, it's almost like a little dome, a pyramid. One side of it has a little cup that looks like a hard contact lens. Depending on if it's a 4-mirror or a 3-mirror lens, you may need to add a little bit of solution there, and that lens goes right up against the patient's cornea. Right? And so there's these different lenses or mirrors that's there so that you can look at the different angles. If it's a 4-mirror, there's only one mirror that you would look, and you would have to rotate that lens on the patient's eye. So because you're touching the patient's eye, we would anesthetize them, keep them as comfortable as possible. Right? There's no need for any fluorescein or any dye with this. It's just a straight light, anesthetize the eye, rotate that mirror to take a look at the angle. And then this is what we would see. So that upper left is a picture of a normal open angle. You can see all the way down to its ciliary body band, so a lot of pigmentation right here. So this is an open angle. Right? And then as you rotate that lens, you can see different quadrants of that angle. And that bottom right-hand corner is showing you a picture of what PAS will look like. So the anterior synechiae. So you'll see this projection of the iris right here. That's touching the corneal. Okay. And right here. So with the iris, it's going forward and it's stuck to the corneal endothelium. All right, treatment. So ultimately, it's surgery for these patients. Trabeculectomy or lectomy, or a shunt is done. And this is done in areas that there is no PAS, right? You would do a goniosynechialysis to break that synechia. All right, so let's go ahead and take a break here before we jump into the next category. But before we go, any questions? All right, so I'm going to take a break.
Yeah, I fucking hate you. I was
I would have appreciated that more.
I got scared too. I was like, what?
She just told me to study everything. I'm like, wow. Fucking wild. Oh, I know I got that one. That was one of the FDA was about like suicide. Like that's the only one that makes sense. I got that one. So I know I wasn't getting points back for that. Well, the right answer was suicide. It was the one. It was like, which one of these should you report to the first? And like suicide. I think I put that one. I think it tells you on your so like go to red. It tells me like before. Okay, so it tells you where you're testing graded your score like 2 questions that would affect your test. So what that what form do you guys?
They all work.
So you get it wrong.
Depression. It treats anxiety. Right. So which this is we don't like it. I can find some thanks for making me this is
I had that once. Like the power cord just died on my original my one. It died and I had to buy like I bought like an offering. I'm gonna find a Microsoft one. And then I bought an offering on Amazon. Why was you buy a power cord? Like mine perfect. Mine was perfect. What is it?
It's a three.
How does that work? Oh, that's if you make that question like what is going to be seen as most effective for weight loss and things like that. So honestly, with these meds, it's not going to be based on which one's the most effective. Because then it's like drug choices. It's more of like what their average effect and how it's going to affect the patients.
But they are.
Yes. I've learned that it's like you know, like the review type of side and time with safety.
That's not even on the top. You know how there's a block that says drug choices, and then it says like.
I don't know. Maybe find out.
I know first night is
But it also lists. So see how it doesn't list out.
no, it does. Oh man, if you don't want me.
I don't know how I would have been able to do
It's no different than what you're wearing. You gotta put it over your top like this. It's over your head. It's not now I can't go outside.
But that's why it's
I can't go over my feet where my feet is really my right hand exposed on my mouth too long. I can't do my hand. Tuck it in for a few minutes. I just put it in my pocket.
Oh.
Alright, can everyone see this real quick? Alright, something me and Jake have been talking about, but we've all kind of seen it. We just saw a very bad medical last semester, but we are being very disrespectful to our instructors by not paying attention at the start of class and just going into and out of breaks. Okay, we have no 5 up here. We got no 4 in the back. Last time I checked, there's only 1 person that's even close to that rank in this room right now. All right, people that are up on this podium are going to be our bosses one day. Okay, they're going to be our brigade PAs, brigade surgeons, whatever. So wherever we're going, right? So show a little more respect, right? We're in this building. We're here to learn. It's not social hour. It's not happy hour. It's not time to jaw jack with your buddies. We're going to be off at freaking noon today. It's not before that. So plenty of time to go figure out what you did last night after class. Okay. When we're in this building, when we're in this classroom, it's time to learn. Ass is in your seat. Position forward to the instructor that's ready to teach. Okay. Anybody have a problem with that? Let's get better at it. Okay. We built up a lot of goodwill based on our good grades on tests and just our overall demeanor as a class. So let's not start to erode that just because our britches are getting too big. Okay? We're only in halfway through the second semester. We got 10 more months here. Okay? Let's lock it up a little bit. Okay?
So prior to the break, we talked about your open angle glaucomas and your angle closure glaucomas. Those are the two biggies that we definitely want to focus on. The next few types of glaucoma, it's good to know. I mean, some of them, even I, as an optometrist for 15 years, haven't seen one and just know it because someone taught me it. Like I said, know the open angle glaucomas, know the angle closure ones for sure. Alright. So moving on, congenital glaucoma. These are in our little kids, right? It's not associated with other ocular conditions. It is usually seen with Sturge-Weber syndrome. And Sturge-Weber is a rare neurological condition that causes abnormal blood vessel development. And a lot of times you'll see they'll have this very particular birthmark called a port wine stain. Signs of congenital glaucoma: enlarged globe, or sort of enlarged eye, and their cornea diameter tends to be over 12 millimeters before the age of 1. Right? There is some corneal edema going on, tearing, photophobia, blepharospasm, and increased intraocular pressure, as well as an increase in cup to disc ratio. Other signs that you can see is these linear tears in the Descemet's membrane, and they tend to follow a horizontal pattern called Hobbs striate. You can have some corneal stroma scarring, redness of the eye, so conjunctival injection, and there tends to be a myopic shift in their refractive error, so a more nearsighted shift to their prescription. Now, some of the differentials that you need to think of when you're ruling out or deciding on congenital glaucoma is that there are 3 different conditions that can present with very similar signs. So the first one is megalocornea, and that is when the cornea diameter is bigger than 14 millimeters, but overall everything else is healthy, right? So they don't have this increase in intraocular pressure. There is no changes to their optic nerve or any type of field loss. You can also have nasolacrimal duct obstruction that can cause a little bit of injection in the conjunctiva as well. But again, you're not going to see that increase in intraocular pressure. The other differential is a forceps delivery, right? And so that can sometimes cause tears in the Descemet's membrane as well, but that pattern tends to be vertical versus that horizontal linear pattern with congenital glaucoma. So here's an example of that Hobbs striate, right? So you'll see the lines going across that cornea in a horizontal pattern. And then another one. And then this here is not Hobbs striate. This is from a forceps delivery. And if you look closely, you'll see that the linear tears go in a vertical pattern. Yeah, it's really hard to see in these pictures, but you'll have these little vertical lines right there. All right, so this little baby right here, what they're trying to show you in this picture is how big that eyeball is and how big that corneal diameter is. So even by moving the lids, the upper and the bottom lid out of the way, you still see lots of eye and very little white parts of the eye. then the next picture, this baby has some corneal haze going on, so that cloudiness of the cornea, and that's due to corneal edema. All right, ultimately, the treatment for these patients are surgery. Right, we can prescribe some medicine, but that is really just a temporary fix until the member or the patient is able to get surgery done. So 3 different types of surgery: goniotomy, trabeculotomy, and trabeculectomy, right, where we're creating that shunt. So secondary glaucoma. The first step is traumatic glaucoma. So the name in itself, there's some sort of trauma that had occurred. And this tends to be more common in males. And it's associated with blunt trauma. And this trauma will cause an angle recession, where it starts to affect the pathway for that outflow of the aqueous humor. And when that happens, you run the risk of developing some damage to the optic nerve, right? So again, damage to optic nerve, increased pressure, we're thinking glaucoma. And the treatment would be similar to your POAG, your open angle glaucoma. During my 4th year of optometry school, it was my very first rotation. It was out in the middle of nowhere in Vermont. And I was at the VA out there. And all of the optometry students, regardless if it was your first rotation or it was your last rotation before graduation, you had a full call. I chose optometry because I did not want a full call, so it was a surprise. And so, of course, every time I had the beeper, it always went off for something crazy, right? And so, beeper went off. I'm like, oh man, gotta go respond. So we went down to the ER, and all I heard was this patient moaning. I'm like, ooh, I need my attending right now. And so what happened was this patient, and I'm gonna probably butcher this because I'm not an expert at hanging shingles, but the patient was attempting to hang shingles. So I guess these are things that you hang from like the roof. And so he anchored it on one side, was working his way on over, and climbed down his little ladder, was walking, and whatever he had anchored, he didn't do a very good job, and it popped off. And it swung down like a pendulum and caught him. Reflexes were amazing because he did not scratch his cornea. He had this nice little laceration that stopped at one lid margin and then continued on. But because of that force, that blunt force, he ended up with an iridodialysis, meaning he ripped the root of that iris that connects away. So he has this flapping iris going on, some hyphema, so bleeding in the anterior chamber and whatnot. And so the reason why I bring it up is because that, obviously because it affected that angle, we're going to experience an angle recession. And that was, we sent him off to ophthalmology. They ended up suturing that iris back down. But this patient would be monitored for the rest of their life because we worry about glaucoma in the future because now, again, that outflow is affected. All right. I don't think he's hanging shingles anymore, but... All right, neovascular glaucoma is another type of secondary glaucoma. And so yesterday we talked about certain conditions that would cause neovascularization to occur. And it's not just neovascularization that occurs on the retina, but it actually happens to the different parts of the eyes, into the iris and that angle. All right, it can cause some anterior synechiae that closes off that angle, driving that intraocular pressure up, and then again causing damage to that optic nerve. There's a list of different causes, so diabetic retinopathy, your vein occlusion, your artery occlusion, and then ocular ischemic syndrome. All right, so signs and symptoms of neovascular glaucoma. For some patients, they're asymptomatic, but others can experience some pain, red eye, some light sensitivity, photophobia, decreased vision, and the severity of your symptoms will probably indicate how high the pressure is. So if it's normal intraocular pressure, probably asymptomatic. elevated intraocular pressure, you're going to experience that pain, redness, photophobia, and decreased vision. All right. So treatment is usually done. Say if a patient has neovascular glaucoma in both eyes, the surgery is going to be done on the eye that has the one with more useful vision. All right. You can see we would prescribe timolol, which is a topical medication, but ultimately surgery would happen for these patients, and we would either do the filtration surgery, and then PRP, which is that laser procedure that would address the underlying condition. All right, so neovascular on the iris is really pretty. So whenever we're looking at the patient in the slit lamp, we're looking at the pupillary margin, all right, and then you see this lacy red tissue that's going on, and that is your neovascularization. All right, so we're looking closely at that pupil margin, and it's this red lacy vasculature that's happening. Lighter colored eyes, super easy to see. Darker colored eyes, that might be a little bit more difficult. All right, you can also have an extensive form of neovascularization going on, and that spans across the iris. And the last of it is the steroid response glaucoma. All right, this is due to the increase in intraocular pressure due to steroid use. So for ophthalmic medications, steroids, it usually is when a patient is on that medication for about 2 to 4 weeks. You can also see an increase in intraocular pressure with other forms of steroids, so high dose creams, inhalers, nasal sprays, and this can cause damage to the optic nerve if you leave it untreated. So for us, when we're seeing a patient who has some sort of inflammation, that course of steroids is pretty short. When we're talking about patients who've had refractive surgery, right, there are PRKs in particular, they tend to be on steroids a little bit longer, and so that's where you do want to make sure that the patient is coming in for their follow-ups, or I need to make sure that they're coming in for their follow-ups, and we're measuring their intraocular pressure every single time. A lot of times patients will say, I can see through walls, my vision's 20/20 now, I don't need to come in. But if they're still on the medication, they do need to come in so that we can do a quick check on that. I've had maybe 2 patients who were steroid responders, and it was luckily, it was towards the end of their taper, and so all we needed to do is just, one, I discontinued the steroids, and the other one we just added a drop to lower their pressure. And so it goes to our treatment, discontinuation of the steroid drops, or maybe decrease the dosing, and so maybe starting that taper a little bit sooner, and then adding the intraocular pressure lowering medication. All right. So we covered a lot of different glaucomas, but there are more, such as inflammatory open-angle glaucoma, exfoliative glaucoma, phagolytic, and postoperative glaucoma. All right. 2 main things when it comes to diagnosis is that we need to make sure that there is no optic nerve damage, all right, and that there's no visual field loss, because those 2 are indicative of glaucoma. Intraocular pressure alone is not enough to diagnose glaucoma. That is it. Any questions? Not as crazy as retina. Still maybe dry as retina. But yeah, so glaucoma, like I said, the biggest takeaway, primary open angle, right? A lot of the congenital ones and stuff like that, that's really rare. And then the angle closure, because that can happen sudden, and the main thing is to try to break whatever is causing that angle closure. And so there are certain medications, a lot of times it's already packaged up as a kit, and so you don't really have to think too much about it. But Major Heinen was bringing it up during the break that you guys are frontline, and so if this happens downrange, that you guys would be addressing this angle closure attack before they get to us in optometry. Right, so I would just talk to your pharmacy team and your optometry team just to know exactly where that stuff is, so that you guys are well prepared. Okay. That is all I have for y'all today. See you guys on Monday.